So I'm going to move on to the next speaker, who is Dr. Indira Garcia Cordera, who's doing her PhD, who did her PhD in biological sciences at the Faculty of Exact and Natural Sciences in the University of Buenos Aires, Argentina. And there she studied neurodegenerative diseases and analyzed structural and functional connectivity patterns associated with social cognitive deficits. She's now working at the Center for Research in Neurodegenerative Diseases and the Canadian Concussion Center, where she's applying some of her analysis to the study of neurodegeneration in concussion. I will let Dr. Cordera.
Okay, hello, can you hear me well?
Yes.
And can you see my screen?
Yes.
Great. So thanks for the opportunity to present my work in this conference. My presentation is called Brain Structure and Functional Imaging in Athletes with Repetitive Concussion and Biomarkers of Neurodegeneration. So there is accumulating evidence that repetitive concussion is a risk factor for chronic encephalopathy, early onset Alzheimer's disease, and other dementias. Exposures to concussion is very frequent and in contact sport athletes and is higher in professional athletes. So therefore, former contact sport athletes present a higher risk to develop dementia. Exposure to multiple concussion contribute to delay brain atrophy, and disruption of functional connectivity. Specialists studies have shown the decreased connectivity of the default mode, the salience, and the frontoparietal networks in patients with a history of repetitive concussions. These changes are also observed in neurodegenerative disease. Moreover, biomarkers could help to identify patients at high risk of neurodegenerative disease. Particularly, biomarkers of neurodegeneration could be useful to detect and monitor ongoing pathophysiological changes that are occurring in the brain before the onset of symptoms. Neurofilament light chain protein is among the most promising biomarkers for neurodegeneration, as elevated values have been shown in several neurodegenerative disease and in contact sport athletes. Also, cerebrospinal total fluid has been proposed as a marker of tau-related neurodegeneration and has been found increased in former athletes and with repetitive concussion. Finally, PET-tau imaging can be also used as a biomarker of neurodegeneration, as PET-tau patterns strongly overlap with brain atrophy and pathology. So in this study, we test whether concussions can be associated with neurodegenerative processes that affect specific brain structure and connectivity networks and increase vulnerability to dementia. To do that, we assess cognition and behavior, brain structure and functional connectivity in former contact sport athletes with repetitive concussions and biomarkers of neurodegeneration. So for the methods, I am going to walk you through the biomarkers we use to define groups, the participants we recruited, and the neuropsychological assessment and analysis performed. So the cohort was divided into neurodegenerative biomarkers positive and negative groups to compare participants with evidence of underlying pathology and at higher risk of neurodegenerative disease versus participants without any evidence. The biomarkers we used to split the samples were CSF total tau, PET-tau, and serum NFL, and here you can see the threshold we use for positivity. And the criteria is that the participant is considered positive when at least one of these three biomarkers is positive. So we were able to split our sample in negative or positive participants for biomarkers of neurodegeneration. So here is the demographic information of the sample. There are 28 positive and 18 negative participants. All are males and older than 40 years old, and groups were matched for age, education, number of concussions, and APOE frequency. The exclusion criteria was a clinical diagnosis of dementia or any known psychiatric or neurological disorders. So the following tests were included in the neuropsychological assessment: the trait making A and B, the PAS auditory serial addition test, the digital span, the verbal fluency, rate auditory verbal learning test, and the personality assessment inventory. And for the methods, let's start with the principal component analysis. These are all the scores that were included in the PCA analysis. And the main purpose of this analysis is to know which of the tests explain the majority of the variance, and then to generate individual PCA components like a composite score and compare them between groups. Then patients also underwent MRI and functional MRI. So the T1 images were segmented into gray matter volume maps through voxel-based morphometry, and the maps were compared between positive and negative groups. For functional connectivity, two analyses were performed. The first one was a C.E.T.-based connectivity analysis to obtain the resting state networks. As C.E.T.S, the precuneus was selected to determine the default mode network, the right anterior insula for the salience network, and the left and right superior parietal gyrus for the frontal parietal network. The connectivity was obtained between the C.E.T and the rest of the brain, and group comparisons were performed with the connectivity maps of each network. As a second step, the peak of atrophy was chosen as a C.E.T, and the connectivity between the C.E.T and the rest of the brain was calculated. Then those maps were compared between groups. So for the results, the PCA evidenced two main components explaining the 38% of the variance. And the table here shows the main contributors to each dimension. And you can see that in the first dimension is constituted principally by memory and executive scores, and then dimension 2 by executive and behavioral scores. When we compare the extracted PCA components per individual between groups, we only found differences in the first dimension. When we look at the scores separately, we found subtle differences between the positive and negative groups in the first dimension, always with worse performance for the positive group. However, the significant differences were lost after the correction for multiplex comparisons. For gray matter volume differences, the positive group presented more atrophy in the left frontal superior and medial gyrus and in the gyrus rectus in comparison to the negative group. The left frontal cluster inside the green circle is the one that survived the correction for multiplex comparison, and the one we use as a C.E.T for the last functional connectivity analysis. For functional connectivity networks, the negative group presented more connectivity in the default mode network and in the salience network than the positive group, and the positive group present both enhanced and decreased connectivity in the frontal parietal network. Finally, when we look at the atrophy peak connectivity, the negative group presents more connectivity between the peak that is located in the left superior frontal gyrus and the frontal pole. So the PCA results show a mixed component of memory and executive functions that was different between positive and negative groups. The positive group always displayed worse performance in all tests belonging to the dimension 1. However, no differences were found when the scores were individually analyzed and corrected for multiplex comparison. So maybe this highlights the importance of using composite scores, as we did when we extracted the PCA individual components in this type of participants to detect subtle differences in cognition and behavior. Neuroimaging results show that the positive group present more atrophy in the left frontal superior gyrus, disconnection of the default mode network and the salience network, and both enhanced and decreased connectivity in the frontal parietal network. Also, frontal disconnection associated with atrophy. So maybe this can mean that the frontal atrophy and abnormal connectivity, especially in the frontal parietal network, may underlie the subtle connective deficits found in the positive group. So finally, the study presents several limitations. For example, only males were included in the sample. Also, as the participants play different sports, we cannot discard a differential injury mechanism between groups. Then not all of the participants had all the 3 biomarkers that I mentioned. So in those cases, we only keep the information that we have. Then, while NFL and CSF total tau and p-tau are associated with different aspects of neurodegeneration, NFL is more neurodegeneration in general, while CSF total tau and p-tau are associated with tau neurodegeneration. And as this is an ongoing project, I am currently working on analyzing the associations between cognition and behavior and the functional connectivity. So that's why those results were not showing here. So to conclude, biomarkers of neurodegeneration can provide a sensitive tool to detect participants with structural and functional changes and may associate with higher risk to develop dementia after concussion. So thank you very much.